Assalamu alaikum everyone. This is Nour Elshimy. I'm a second year medical student, and inshallah today I'll be walking you through your anemia lecture. So we're going to be talking about the different types, classifications, and causes of anemia, inshallah. And then we're going to move to the blood groups and the different systems we have. So without further ado, inshallah, let's get started. Those are going to be my objectives for today that I'll be covering in my slides. And also, guys, please do not mind the amount of slides. Those are just transition slides. But yeah, at the end of the day, it's like a 40 lecture slide. So inshallah, it's not much. And of course, at any point, any time, please stop me if you have any question. Okay? So, Bismillah ar-Rahman ar-Rahim. Okay, anemia. So first things first off, what is anemia? Now, anemia is a red blood cell disorder in which we would have a reduced amount of hemoglobin or hematocrit in our red blood cells. And it is specific to age and gender. Okay, so you have to consider the age and gender because the normal ranges is different for depending on age and gender. Now, just a heads up, guys, you don't have to know the ranges because they provide it to you for in the exam. But just have it in the back of your head. You actually don't have to know it. They're gonna be there in the question, but you're just gonna have to be able to know if it's below or above normal. And of course, we have a lot of causes of anemia, and it results from a wide variety of disorders, and that's why we're gonna have to take different investigations or different investigations to be able to diagnose correctly. And one of the most important things we should do is complete blood count, which is CBC, and we're going to talk about this later on, okay? So, as a physician, for you to be able to classify anemia, you're going to have to use two complementary approaches. First off, you have the morphology. And morphology is technically the study of the structural features or different characteristics of the cells in our body. So it's based on the appearance of our red blood cells. So size, the hemoglobin content, and so on. And in order for us to be able to distinguish that, we're going to have to run some tests, including CBC and sometimes peripheral spear, which is basically the appearance of cells under the microscope. Secondly is the underlying mechanism. Underlying mechanism is basically, it tells us the cause of anemia or why it happened. And again, the test we run to be able to know what the cause is the reticulocyte count, and we're going to get to this inshallah through the slides. All right. Right. So the investigations would be, as I mentioned, first line investigations, the CBC, which is the complete blood count, and the reticulocyte count to identify the underlying mechanism. Now, what even is CBC? From its name, we have its complete blood count, okay? So complete blood count, basically, it's a test that tells us about all the different cells we have in our blood, okay? So it's a test that measures red blood cell count, the hemoglobin, the hematocrit, some red cell indices like MCV, MCH, MCHC, and white blood cells and platelets. Now, in order for us to know if someone has anemia or not, we're going to have to look at three different measures: the red blood cell count, hemoglobin, and hematocrit. Those three tell us if someone has anemia or not, but it does not tell us if which type of anemia they have. So in order to be able to classify the type of anemia, we're going to have to look at MCV, MCH, and MCHC. We're going to talk about each and every single one of those, but don't worry. Now, white blood cells and platelets, it really shouldn't be our concern for today. It's not really relevant to anemia or red blood cells, so we're not going to talk about this much. And again, for morphology, we do complete blood count, and for underlying mechanism, it is the reticulocyte count. So let's start off by talking about the complete blood count. You have a patient in your clinic or whatever, and you are suspecting anemia. Okay, so what are you gonna do? Your first thing, you're gonna order a CBC. This is the first thing we do as physicians or doctors to be able to diagnose someone. So when you run the CBC, you're gonna have something that looks like this. Now, there are a lot of test names, there are a lot of things. But if you are concerned with anemia, you're going to have to look at specific tests, okay? And those are the tests that you're going to be looking at. There are 7: red blood cell count, hemoglobin, hematocrit, MCV, MCH, MCHC, and RDW. We're going to talk about each and every one of them. I will tell you how it helps us to classify the anemia, or to even know if someone has anemia in first hand or not. Okay. So starting off with red blood cell count. So from its name, it's the total number of red blood cells we have in our body. The normal ranges would be 4.5 to 6.0 times 10 power 12 for males, and it's less for females. Again, you don't need to know the ranges. You're going to be provided this in the exam. All right. And as I mentioned, red blood cell is one of the measures that if it goes below normal range, you just know this person has anemia. All right. So if it's below normal, they have anemia. Now, this is just a picture that shows you how red blood cells normally look like under the microscope. As you can see, they're beautiful right there. All right. Moving on, we have hemoglobin. And this is actually one of the major measures we need to do or test for anemia. Now, what even is hemoglobin? As you can see, as the word tells you, it's divided into heme and globin. So speaking of heme is basically iron plus protoporphyrin. We know iron, it's a nutrient, it's a mineral, okay? And protoporphyrin is basically the base ring structure that iron attaches to form the heme, all right? Then the other component is globin. This is the protein part of the hemoglobin, and it's composed of 2 alpha and 2 beta chains, um, where like they attach to heme, and then they form the hemoglobin that transports oxygen. So what's the major function of oxygen? It is it's a protein found in the red blood cells that carries oxygen from the lungs to all the body. So this is a red blood cell right there. You can see the hemoglobin attached to the oxygen, and it's going to be transporting it to all the body. All right. And again, if hemoglobin goes below the normal range, this indicates anemia. Okay. All right. Hematocrit. Now, hematocrit tells you the percentage of red blood cells found in blood, or the amount of red blood cells proportional to the blood. And this is a formula for you to calculate hematocrit. I don't think it's relevant. I don't think you're going to need it, but just keep it in the back of your head. Hematocrit is basically the red blood cell count times MCV. We're going to talk about MCV. It's basically the average cell size of the red blood cell. And again, if it goes below the normal range, this tells us that this person has anemia. All right. Now, this photo just tells you if you get a blood sample and you leave it for some time, the red blood cells are gonna dissociate kind of from the blood plasma, and they're gonna be packed down there. Okay, so this amount of red blood cells, or this packed red blood cells, basically tells you what hematocrit is. So this is the amount of red blood cells proportional to the blood as a whole. Right. Then comes next MCV. Guys, also, am I moving too fast? If I'm moving too fast, please tell me to slow down. Or is it fine? All right. Okay, let's continue. Now, let's talk about MCV. MCV tells us about the average size of the red blood cell in blood. All right. So we have 3 scenarios right here. First off, the normal average size of the red blood cell, which we call normocytic. And let's break down this word. Normal means normal, cytic means cell. All right. So normocytic means that the size of the red blood cell is in the normal range, which is 80 to 100 femtoliter. Now, I think it's very easy to memorize the range here rather than the other ranges, because they're kind of in decimals. So also like try to familiarize yourself with the ranges regards MCV. Now, so if the normal range is from 80 to 100 femtoliter, then if it goes below 80, this is where we call it microcytic. Micro means small, and cytic is the cell. So anything below 80 femtoliter, we're going to call it microcytic. It's smaller than average. And same thing, if it's above than 100, then it is a macrocytic. Macro means big, cytic cell, so it's a big cell. All right? Okay. Now, MCH tells us about the weight of hemoglobin in the average red blood cell. So, if we're talking about weight, we're talking about the color, the amount of hemoglobin in the red blood cell tells us about the color, all right? So if we have a normal amount or normal weight of hemoglobin in an average red blood cell, we're going to call it normochromic. Normal, again. Chromic means color, all right? So if it's within the normal range, which is 26 to 34 picogram, this is how it's supposed to look like, okay? But if it goes below the range, it's going to be hypochromic. Hypo means less, below. So below the average, hypochromic, it's going to be hypochromic, so less color basically. So it's going to look paler. So as you can see right there, it looks so much pale in the center, right? Type. If we have hypochromic and normochromic, do we expect to have hyperchromic, sorry? Do you guys think we have hyperchromic? No, right? Okay. Do you guys know why? Exactly. Good job. So we cannot have hyperchromic because the average red blood cell has a limited capacity of hemoglobin. If it exceeds this amount of hemoglobin, or this weight of hemoglobin, it bursts. And that's why we'd have no such thing as hyperchromic. Okay? Type. Now, MCHC tells us about the concentration of hemoglobin in the average red blood cell. And the normal range is 32 to 36. Now, regards anemia or what you guys are like, you shouldn't be concerned much about MCHC as much as you should be about MCV and MCH. MCHC is only clinically important or clinically significant in 2 cases. If we have high MCHC, it tells us we can find it in hereditary spherocytosis. So to sum this thing up, hereditary spherocytosis happens when there is a membrane defect for whatsoever cause, and when the cell membrane of the red blood cell gets defected, the red blood cell loses its surface area. Okay, so it becomes spherical in shape. So we call it spherocyte, because normally the red blood cell or the cells in our body, they do not have a regular cell membrane. Okay, so it's not like, it does not look like a sphere. It doesn't normally look like that. So in case of a membrane defect, it's going to look like a sphere, we call it spherocyte, and it becomes very dehydrated, so the hemoglobin concentration inside the cell increases. Okay. And it's also found in autoimmune hemolytic anemia. So this also happens kind of the same way. So there's partial loss of the membrane, or the membrane is not very regular because of antibody attack. So again, it's going to look like a sphere, so spherocyte formation. And again, it's going to be less hydrated, so dehydrated, and the hemoglobin concentration inside of the cell would increase. So this is how it would normally look like. This is a normal red blood cell, and this is a spherocyte. As you can see, it's more like dense in color. So this just shows you it's very it has a very concentrated amount of hemoglobin inside a smaller volume. All right. This is only the clinical significance you guys need to know about MCHC. There's nothing much more you guys need to know about this. Type. Now, RDW is red cell distribution width. Now, I don't think Dr. Rehan went over this very, very much, but I want you guys to know this just to give you like the full picture. And it's very easy. It's a very easy concept. So RDW basically shows the difference or the variation of sizes in red blood cells. So if we have a smear where we're looking at red blood cells under the microscope, and if we see that the sizes are variant, so there are so many different sizes, this is what we call, so like high variation, it's going to be high RDW. However, if we look under the microscope and the sizes are similar, this is what we call low RDW. So if there's little variation, so they're similar in size, this is low RDW. However, if we have high variation, so mixed size or different sizes, this is what we call high RDW. And because we're doctors, we need to have specific terms, okay? And for this, we use the term anisocytosis. Okay, so bear this in mind. High RDW means anisocytosis basically means that we have high variation in the red blood cell size. All right. So if I give you those two pictures, which one do you think has a high RDW and which one do you think has a low RDW? Let's say this is A and this is B. Can you guys tell me which one is high and which one is low? Okay, bravo. Good job, guys. All right. Okay, so this one, the right one, has a high RDW because you guys can look at the different sizes. We have a very small red blood cell, and then we have a medium-sized one, and then we have a big one. So there are different variations in the size. Okay, so this is what we call high RDW or anisocytosis. On the left image, we have a normal or a low RDW because they have similar size. They're in similar size, okay? Clear? Okay. So this is our first checkpoint. Does anyone have any questions regards whatever I covered in the previous slides? Okay, the difference between microcytic and anisocytosis. Microcytic, it tells us about the size of the cell. Okay, so microcytic, it would be a small size cell. Anisocytosis is basically when we have different cells right there, okay, and they are different in size. So this is, let's say, a microscopic slide. Those are different red blood cells. You have medium-sized cells, you have small-sized cells, you have big size cells. So there's a variation in size. This is what we call anisocytosis. All right, so it doesn't necessarily have to be only small size cells, but it's basically tells you about the variation in size. Clear? Okay. So I have any more questions? Okay, let's move on. So I have a question for you guys. Is anyone willing to volunteer and help us out? You guys can unmute if you want. Anyone? Okay, guys, just tell me the answer. What do you guys think the answer is? Okay, I have different answers here. All right, okay, let's see. Danielle, a 20-year-old college athlete, collapses during football practice. In the ER, the doctor suspects dehydration and possible anemia. To evaluate his blood composition, the doctors ordered a CBC. The lab report highlights the proportion of red blood cells compared to the total blood volume. Which CBC parameter does this refer to? I have a lot of different answers, but alhamdulillah, the majority answered it right. The answer here is B. So the proportion of red blood cells compared to the total blood volume tells us about the percentage of red blood cells, basically. Okay, so it's the same as packed red blood cells. It's the proportion red blood cells to the total blood volume, same as percentage. They all refer to hematocrit. Okay, now why it's not MCH or why it's not MCV? MCH talks about they all talk about hemoglobin. MCH talks about hemoglobin content in the red blood cell. We did not mention anything about hemoglobin here. Okay, why it's not D? MCV refers to the size. We did not mention anything about the size here either. So uh, it's not C nor D. I don't think anyone said A. So, okay. Hematocrit was basically, let me actually go back. Okay. Hematocrit tells us the percentage of red blood cells found in blood. Okay. So basically, the amount of red blood cells proportional to the total blood volume. This is basically it. When you see the word percentage or red blood cells proportional to the total blood volume, this is what we call hematocrit. And usually we refer to hematocrit as percentage, but this was kind of a tricky question where it kind of played with the words a little bit. But yeah, it's either this, they're either going to tell you percentage of red blood cells or a red blood cells proportional to the total blood volume, which is, in other words, the percentage. Okay? Clear? Okay, great. All right. Okay, guys. Type. Right now, we talked about the different tests, the different indices, MCV, MCH, and all of that. But what concerns us the most is MCV and MCH. Why? Because those two can help us classify the type of anemia. Okay? So let's see how that happens. Hold on. Okay. So if you combine MCV and MCH, again, let me remind you guys, MCV had to do with the size of the red blood cells, and MCH had to do with the hemoglobin content inside each red blood cell. If you combine those together, you're gonna have three different scenarios or three different cases. You're either gonna have microcytic hyperchromic, so low with low, or normal with normal or big. Let me explain. So hyperchromic microcytic, we combined MCH, low MCH with low MCV to make hyperchromic microcytic anemia. So this means we have a low MCV below the normal range and low MCH. Low MCV means smaller size of red blood cells. Low MCH means less hemoglobin content inside each red blood cell. If we have hyperchromic microcytic, we're going to have probably what? Normal chromic normocytic, which means we have a normal MCV, a normal MCH, so normal sizes of red blood cells, and normal hemoglobin content inside the red blood cells. Okay? And finally, we have the macrocytic. Now, in this case, we cannot say macrocytic hyperchromic because hyperchromic is not a thing, right? So it's only macrocytic. Okay, so macrocytic refers to a high MCV. All right. طيب, let's take each one and talk about them further. Starting with hyperchromic microcytic. So again, hyperchromic microcytic refers to anemia with small red blood cells, so low MCV and reduced hemoglobin content, low MCH. So how are they going to look like under the microscope? They're going to look pale and small. Okay. طيب, they're commonly found in iron deficiency anemia, thalassemia, and anemia of chronic disease. I want you to focus more on iron deficiency anemia. I have it underlined because this is what the doctor stressed on more. Okay. And this is how they look like under the microscope. I got you. This is how a normal microscopic image of red blood cells should look like, and this is how abnormal it looks like in case of hyperchromic or microcytic anemia. So those are normal average size cells. However, here you can see they're kind of small and they're very pale in the center. And this is what we call central pallor. Central pallor refers to the center just being pale. Why? Because we have hyperchromic. Hyperchromic means we have low hemoglobin or reduced hemoglobin content, basically. So it's not giving it the much color, and that's why it looks pale. Okay? Like, moving on. Since I mentioned iron deficiency anemia is important, let me talk a little bit more about it. So iron deficiency anemia is a very common type of anemia. It's the most common type of anemia, and as the name implies, it's caused by reduced iron. And why is this important? As I mentioned in the beginning, iron is part of heme, right? Heme is needed for hemoglobin. If we have reduced iron, we're not going to be able to make hemoglobin. And if we're not going to be able to make hemoglobin, we're not going to be able to transport oxygen to all the body cells. And that's why we have anemia. All right. So the causes could be different reasons, okay? Could be chronic blood loss, because if we lost a lot of blood, we're losing a lot of red blood cells, so anemia, or increased demand. So let's say in case of pregnancy, if a mom is pregnant with her baby, so obviously she's gonna need more iron for herself and for her baby. So sometimes pregnant women do suffer from iron deficiency anemia because you're gonna need to take a lot of iron supplements for yourself and for your baby. And lastly, decreased intake or absorption. So basically, you just you do not take enough iron from your diet, or you have some certain type of disease. I don't you don't really need to know the examples. This is just for your own understanding. But celiac disease here, inshallah, you're going to be taking it in GI. But celiac disease is basically an autoimmune disease that disrupts the small intestine lining, and that's why it makes it harder for nutrients or minerals to be absorbed. All right. And again, lab findings, as we mentioned, iron deficiency anemia, microcytic hyperchromic. So under the microscope, we're going to have low MCV and low MCH, meaning that we're going to have small red blood cells and pale, central pallor, because due to hypochromia. And again, any type of anemia would normally have reduction in hemoglobin and hematocrit. So we're going to also find low hemoglobin and low hematocrit. All right? Okay. Now, if I want to observe iron deficiency anemia under the microscope, this is what you would probably see. So we have a lot of things going on here that we could uh, um, that could help us identify or classify anemia as iron deficiency anemia. And one of the very important things that are already mentioned is it's being microcytic and hypochromic. So if you look at the cells, they're smaller than average and they're pale in the middle. So what do we call that? Hypochromia and microcytosis, okay? So them being hyperchromic, when we describe it, we say that this is hyperchromia under the microscope, and microcytosis, which is basically them being small in size. Now, what else do we see? Do you guys think the sizes are similar, or do you think the differ in size? What do you guys think? Do we have high or low variation in size? Okay. We have, okay, good job, guys. We have high variation in size. We have different sizes, okay? Because look at, okay, let me show you. This is, for example, a small one, or this is a small one, and then you have a bigger one right there. Okay, so this is even bigger. Look at this. Look at those two. They're very close to each other. You can see this is a really big one. This is a smaller one. So we have a high variation in size. And what do we call this? Anisocytosis. Perfect. So high RDW, that means that's anisocytosis basically. Okay. Now, what about the shape? Do you guys think they all have the same shape, or are you guys seeing different shapes? Different shapes, okay? Great. So, bravo, you guys. Okay, great. Okay, so we have different shapes, which we call poikilocytosis. So poikilocytosis is a term used to describe the different shapes under the microscope. And what are those different shapes? We have teardrop cell, literally looks like a teardrop. As you can see here, this is a very clear teardrop cell. This one is another one, okay? And we also have pencil cells, which look like these, and so on, okay? Very easy, very interesting, actually. Anyway, okay, we're done with microcytic hypochromic. Let's move on to normochromic, normocytic. Now, what is normochromic? We said normochromic. Chromic refers to the hemoglobin content. So This is MCH, right? So we're going to have a normal MCH, so hemoglobin content is fine. Normocytic, that refers to the size. Normocytic, okay, it's normal, so it's fine. Normal size. So we have normal size red blood cells and normal hemoglobin content. طيب, if we have normal size red blood cells and we have normal hemoglobin content, then what went wrong? Why do we still call this anemia? Do you guys know? We have normal sized red blood cells and we have normal hemoglobin. Good job, you guys. Okay. Okay. So basically, we're gonna have a reduced number of red blood cells. So if you have reduced number of red blood cells, so overall less hemoglobin and so on, leading to anemia, less transfer of oxygen to body cells and all of that, okay? Even though we have normal sized red blood cells and normal hemoglobin content, it's just about the red blood cells being reduced in number. So what are the different causes of this? So this could be seen in acute blood loss. So sudden blood loss would result in having a reduced number of red blood cells in our body. Okay. However, the remaining red blood cells are still normal in size and hemoglobin content. So this is what we call normochromic normocytic. Okay. Another scenario where you would find normochromic and normocytic would be in anemia of renal failure. Now, again, you guys did not really take this much in details, but I think I want you to have a better picture in your head, and that's why I'm going to go over it really quickly. You might ask, what does kidneys or what does renal means kidney, right? So what does kidney ever have to do with red blood cells? That's a good question, right? So normally, kidneys would release something called erythropoietin. Now, what does erythropoietin do? It goes to the bone marrow. What I like to think about the bone marrow, it's the factory of blood cells, okay? So it goes to the bone marrow and it stimulates it, okay? So it wakes it up and it tells it, oh, we need more blood cells. Please start making new blood cells from stem cells. So the stem cells become red blood cells. This is how it is normally in our body, okay? Now, what happens when the kidneys are not functioning well? Obviously, it's not going to be able to produce erythropoietin anymore. So erythropoietin is not going to be able to go to the bone marrow and stimulate it. So we're gonna have less production of red blood cells, even though the already existing red blood cells still have their normal size and normal hemoglobin content. And that's why we call it normocytic normochromic anemia. Yes, the size is normal. Yes, the hemoglobin content is normal, but the red blood cell production is low. Okay? Like, finally, let's go to macrocytic anemia. Macrocytic, again, let me remind you, macro means big, cytic means cell, so big cell, okay? So anemia with abnormally large red blood cells having a high MCV, okay? Now, what are the different causes for this? We have megaloblastic anemia due to B12 and folate deficiency. I'm going to talk about this more later on. And non-megaloblastic anemia, like liver disease and aplastic anemia. I'm not really going to talk about this much because you shouldn't really be concerned much, but just focus on megaloblastic anemia. It's the main thing here. Okay. Right. So what is megaloblastic anemia? As I mentioned, it's an anemia with abnormally large red blood cells. Okay. So macrocytic anemia with what was I saying? Yeah, increased size of red blood cells. And why does this happen? Because we have impaired DNA synthesis. Now, how is this relevant? Like, let me explain. So, as we said, megaloblastic anemia is a result of B12 and folate deficiency, right? Now, those two things are very, very, very important when it comes to DNA synthesis. How? So, B12 is needed to regenerate active folate. Now, why do we need folate? Folate basically provides methyl groups to nucleotides for nucleotide formation. What are nucleotides? If you guys remember, nucleotides are the building blocks of DNA. So, if you do not have B12, you're not going to have activated folate. And if the folate is not going to be activated, it's not going to be able to function. So it's not going to be able to provide the methyl groups for nucleotide formation. So you're not going to have nucleotides, which are the building blocks of DNA. So you're going to have impaired DNA synthesis. Now, why does it look very big though, if there's impaired DNA synthesis? What happens is that the cytoplasm divides on its own, it starts growing, because it's fine, it's functioning. The issue is with the nucleus, okay? So the nucleus is not dividing, however, the cytoplasm is growing, and that's why it looks very big, okay, in size. And again, what are the lab findings? Microcytic red blood cells, so they're going to have high MCV, and again, with any type of anemia, you're going to have low hemoglobin and low hematocrit, okay? If we look at it under the microscope, it's going to look something like this. So look how big this is. And the hypersegmented lobes inside, you could have up to 5 or more. This is what we call hypersegmented neutrophils. Okay, because of DNA impairment, DNA synthesis impairment. Okay. All right. This is our second checkpoint. Does anyone have any questions? Yes, these are only in megaloblastic anemia, right there. Okay. I'm not going to be able to explain thalassemia because it's a very big lecture and it's not really included in the lecture that I like in Dr. Han's lecture regards anemia. But I think I'm not sure. I think there should be another PAL explaining thalassemia. So okay, normocytic, normochromic, again, normocytic, normochromic. When we say normocytic, that means it's normal in size and it has normal hemoglobin content, okay? But the issue is with the red blood cell production. It's very low, all right? Now, it could be due to blood loss. So if when you lose blood, you lose red blood cells. So you have less hemoglobin in blood, or like overall hemoglobin, basically, to transport oxygen, okay? Or it could be due to anemia of renal failure, because as I mentioned, kidneys release erythropoietin, which are the stimulants of erythrocytes production or red blood cell production. So yes, we have less number of red blood cells, but the red blood cells that already exist in blood, they have a normal size and normal hemoglobin content. That's why we call it normocytic, normochromic. So normal size, normal hemoglobin content. Okay, great. Okay. Can you guys answer this question? Okay. Good job, guys. Oh, oops. Okay. Yeah. You guys were right. It is iron deficiency anemia because, yes, it is. Hold on. Okay. So a 35-year-old married female with 10 years history of, I don't know how to say this word, honestly, presents with shortness of breath and pallor, and her CBC showed hemoglobin of 8, so this is below the normal range. MCV 65, that's also below the normal range. MCH is 18, below the normal range, and RDW 15%, which is a high RDW, okay? So, and yeah, this is exactly how you guys are going to get the questions in your exams. You're going to have the normal range in front of you, so you're just going to have to be comparing, okay? If the hemoglobin is low, the MCV is low, MCH is low, that is microcytic hyperchromic, right? And what did we say about microcytic hyperchromic? The very main important example of microcytic hyperchromic anemia is iron deficiency. Okay, RDW 15%, it's high RDW, so high RDW, basically is anisocytosis. And remember when I showed you the microscopic image of iron deficiency, we said that it has high RDW or anisocytosis. So all these findings indicate that this patient or this female has iron deficiency. Clear? Okay. Next question. Okay. Good job, guys. Bravo. They're all right. All right answers. Okay. So, a 70-year-old female presents to your office complaining of easy fatigability, exertional dyspnea, and weight loss. She also complains of frequent falls. Physical examination reveals symmetrically decreased vibratory sensation to the lower extremities. This is all yapping. Okay, you don't need to know anything about this at all. But they say her hemoglobin is 7.8, so this is low, and the peripheral blood smear shows hypersegmented neutrophils. Which of the following is the best treatment for this patient? As you guys said, vitamin B12, because this is a clinical presentation of megaloblastic anemia due to B12 deficiency. Okay, so vitamin B12 is the right answer. Why did we say that? I mean, when they said that hemoglobin is low, this is not quite enough, right? Okay, yes, they told us her hemoglobin is low, but yeah, that indicates anemia, but we don't know which type of anemia until they said that she has hypersegmented neutrophils. Okay, and as I guys as I showed you guys, this is how megaloblastic anemia looks like under the microscope. Hypersegmented neutrophils. So this is a very unique identification for megaloblastic anemia. Whenever you find this, you just know this is megaloblastic anemia due to either B12 and or folate deficiency. Okay. Is the question clear? Okay. طيب طب احنا right now we talked about for complete blood count. We talked about red blood cell count, hemoglobin, hematocrit, which are the three measures we need to know in order for us to tell if someone has anemia or not. So if they're low or below the normal range, someone has anemia, but they're not enough to tell us which type of anemia someone suffers from. And that's why we look at the red cell indices, or so-called MCV, MCH, MCHC, for us to be able to classify the type of anemia. We looked at MCV, if it's an MCV and MCH collectively, if we look at them, we can classify anemia, okay? So we said MCV, MCH together, they could either be hypochromic microcytic, and we talked about iron deficiency in this case, or they could be normocytic, normochromic, and we talked about blood loss and renal failure, or it could be macrocytic, big cell size. This is in megaloblastic anemia. Okay? This is all what we talked about. Now, what's next is the underlying mechanism, or basically the cause of anemia. Okay? And for this, we are concerned with the reticulocyte count. So what is the reticulocyte count? Now, this is basically the number of reticulocytes expressed as a percentage. Now, what even is a reticulocyte? It's an immature red blood cell, or the precursor of a red blood cell, basically. Okay, so before a red blood cell becomes a red blood cell, or before it becomes mature, it was immature, and this immature red blood cell, we call it reticulocyte. Now, why is this important? Because this helps us to tell, it tells us about the activity of the bone marrow, if it's working well, or if it's producing enough red blood cells. Because again, as I mentioned, the bone marrow is the main factory that produces red cells or the blood cells, okay? So if there's something wrong with the bone marrow, it would not be able to produce those red blood cells. And that's why it tells us if there's an issue or not, okay? طيب. So in this case, the reticulocyte count could either be low or high. And because we're extra as doctors, we have to give it a big name. So hypo proliferative or hyperproliferative. So the normal range is 0.2% to 2%. If we have a count that's below 0.2, that's hypoproliferative. Hypo means less, okay? So hypoproliferative would indicate a less reticulocyte count. More than 2%, it's hyperproliferative. So we have an increased reticulocyte count. Okay. Anyway, let's talk more about hyperproliferative. Uh, yeah, let's talk more about this. So hypoproliferative means hypo means less, okay? So there is less production or not enough production of red blood cells due to not enough طبعا reticulocytes, okay? So it's the inability to produce adequate number of red blood cells in response to appropriate stimulus, or basically when the body needs to make red blood cells, it's not being able to respond and produce the red blood cells. So in this case, we're going to have low reticulocyte count indicating that we're going to have less red blood cells, okay? Because the reticulocytes are basically the precursors of red blood cells. And hyperproliferative anemia is usually found in nutritional deficiencies like iron, B12, and folate. So iron deficiency, megaloblastic anemia due to B12 and folate deficiency, they're all hyperproliferative. So when I tell you, for example, to identify or classify iron deficiency anemia based on underlying mechanism, you're going to tell me hyperproliferative. But if I ask you to classify it in terms of morphology, it's going to be microcytic hyperchromic. Okay? So it depends on which mechanism I want you to classify it with. If it's underlying mechanism, it's going to be hyperproliferative. If we're talking about morphology, microcytic, hyperchromic. Overall, iron deficiency is hyperchromic, microcytic, and hypoproliferative. Okay. Now we talked about anemia of renal failure as well. This is an example of hyperproliferative anemia. And finally, aplastic anemias. I'm going to also give you an overall idea of what aplastic anemia is. Again, this is just for your own information. It's not really stressed on much on your slides. I don't remember Aslan seeing them on your slides, but this is just to give you يعني, a full picture. Okay? So aplastic anemia, from the name, aplastic means no production, basically. So as we said, the bone marrow is the one that's responsible to produce blood cells, okay? In case of aplastic anemia, there's an issue with the bone marrow where it does not have hematopoietic cells or it does not have stem cells for it to be able to produce blood cells. And this term, we call this pancytopenia. Pancytopenia, basically, when we have low red blood cells, white blood cells, and platelets. So basically all blood cells, okay? Under the microscope, this is how it's going to look like. It's going to look empty. It has white spaces, okay? It's very empty, okay? And we have no stem cells, so we're not going to be able to produce enough blood cells, all right? And this is hyperproliferative, because obviously, if it's not going to be able to produce red blood cells, then this is hyperproliferative because we're not producing red blood cells, basically, okay? Like the other term is hyperproliferative. Okay, hyper means more. So there's overproduction of red blood cells due to high reticulocyte count. Now, where do we see this? We see this in hemolytic anemia. What is hemolytic anemia? Hemolytic anemia happens due to some destruction of the red blood cells for whatsoever cause. So when we have destruction of red blood cells, the body is going to try to compensate. So what is it going to do? It's going to try to stimulate the bone marrow to increase reticulocyte count or basically increase the precursors of red blood cells for us to be able to produce more red blood cells. Okay? Second case would be bleeding. Same thing. We're losing a lot of red blood cells. So the body again tries to compensate. So it's going to increase the reticulocyte count to make more red blood cells. Okay? Okay. In this way, we are done with the investigations that we are supposed to do in order for us to classify anemia. So we talked about the morphology, the CBC, that we can classify anemia based on morphology or appearance under the microscope or based on the size or hemoglobin content. We talked about underlying mechanism, which is basically the cause of anemia or like what's causing it, or we're dealing with the reticulocyte counts or the precursors of red blood cells if the bone marrow is producing too much or less than normal. Okay? Now, this is a summary for everything that I just talked about. So I think it's gonna be great if you guys go over this really quickly. And I have the main things underlined. Um, and yeah. Now, one thing I want to mention, this all the investigations or all the tests we ran was under first line investigations, which has CBC and reticulocyte count. Now, sometimes we would want to run more tests to confirm the diagnosis. So let's say we have iron deficiency anemia. We did a CBC. We saw that the MCV was low, the MCH was low. Okay, it's hypochromic, microcytic, it's hyperproliferative based on the reticulocyte count, but we want to confirm more. So what are we going to do? We're going to run further tests for iron or ferritin, or in case of megaloblastic anemia, for example, we're going to run some tests for B12 and folate. So this is second line investigations. You shouldn't be concerned much with those, honestly. I think you should be more concerned with this. This is just for the sake of completion, basically. Okay? Okay. Any questions? Okay. Okay. Hold on. Hyperproliferative anemia is basically due to increased production of red blood cells. So you're producing a lot of red blood cells. And when does the body do this? Does this when we suddenly lost a lot of red blood cells. So in hemolytic anemia or bleeding, in hemolytic anemia, there's a there's the destruction happens for the red blood cells, so your body's trying to compensate. So it's trying to make more red blood cells to compensate or replace the lost red blood cells. And that's why it's going to be hyperproliferative, meaning the reticulocyte count is going to be increased to make more red blood cells. Same thing for bleeding as well. So this is just a way for the body to compensate. Okay? Okay. Could be, yeah. Does it happen when the bone marrow is under stress? I mean, I don't know, it depends on the stress. I'm not sure what you mean in this context, but in general, when the bone marrow, I mean, because the bone marrow needs to be stimulated, and it's mainly erythropoietin that that stimulates the bone marrow to produce more red blood cells or reticulocytes, basically. Okay. Any more questions? Okay. Can you guys answer this question, please? Okay, good job, guys. Bravo. Um, So a 30-year-old female with history of whatever this word is for 2 years has hemoglobin of 8, so it's below normal. MCH is 20, it's also below normal, and MCV is 65, which is also below normal. Which of the following is the correct classification for this anemia according to mechanism? So you guys answered it correctly, which is hyperproliferative. Now, why is it hyperproliferative? Based on the findings, we have low hemoglobin, okay, and the, that's basically hypochromic. We have less average size, that's microcytic. And yeah, so this is going to be basically hypochromic microcytic. Now, when do we find a hypochromic microcytic? In iron deficiency anemia. And we said that iron deficiency anemia is also proliferative. All right? So this is how you should think about it. So you should try to know, okay, which type of anemia that is. If they do not obviously mention it directly that, okay, where the body's producing like less or more red blood cells, then you're gonna have to think about the type of anemia, and then you're gonna be able to classify it. In this case, we have low MCH, low MCV, hyperchromic microcytic. Think about iron deficiency anemia, and it's gonna be hyperproliferative. Okay? Okay. And yeah, it's not C because we're asking about the mechanism and not the morphology. That's right. Okay. Like that was it for anemia. I hope I covered everything regards this. I tried to cover everything. I know I added some extra details, but you know, that's just for the sake of your understanding. And yeah. No, hyperproliferative is not another name for hyperchromic microcytic. Okay, let me go back. So basically, where do I go back? Okay. If I tell you to, if I tell you, no, let me go back here actually. Yeah. If I tell you to classify anemia based on morphology, you're gonna tell me it's microcytic hyperchromic. If I tell you to classify it based on mechanism, you're going to tell me hyperproliferative. So it depends on the classification or type of classification I'm asking you to do. Okay? If I'm asking you about morphology, so we're just concerned with the morphology, the appearance, or the characteristic of the red blood cell. Okay? So you're going to either tell me microcytic, hyperchromic, normocytic, normochromic. There's a spelling mistake right there, by the way. It's supposed to be normocytic, but anyway. So when I ask about the morphology, you're gonna either tell me it's microcytic, normocytic, microcytic, normochromic, hyperchromic, whatever. Okay? But when I tell you about the mechanism, it could either be hyperproliferative and hyperproliferative. And what does that depend on? Depends on the reticulocyte count. So if we did a test and the reticulocyte count was below average or below normal, you're going to tell me it's hyperproliferative. If it was higher, it's hyperproliferative. So do not mix those up. Those are just different ways to classify anemia. Okay? So please, in the exam, make sure to know what they're at, which type of classification they're asking for. Is it based on morphology? And so you're going to answer with microcytic, hyperchromic, or whatever. Or is it based on mechanism? In this case, you're going to be talking about hyperproliferative or hyperproliferative. And again, let me tell you the example again. If we talked about iron deficiency anemia, and I told you classify iron deficiency anemia based on morphology, then okay, you're going to tell me it's microcytic, hyperchromic. But if I tell you define or classify iron deficiency anemia based on underlying mechanism, you're going to tell me it's hypoproliferative. Okay? Clear? Yes, basically, hyperproliferative indicates that there is less reticulocytes in the blood, so less red blood cells, while hyperchromic microcytic, there's smaller cells and less hemoglobin content in the red blood cell. Uh, and that's how we classify it based on morphology only. When we talk about morphology, we talk about microcytic, the size, or the hemoglobin content. When we talk about the underlying mechanism, we're talking about the production of red blood cells. You're welcome. Okay. Okay. Do you guys need a break or shall I continue? We're done with anemia and we just have the blood groups left. There's nothing much. So tell me, if you guys need a 5 minutes break, we can do that. Okay. Then let's continue. Type blood groups. This is where things get more interesting. I think blood groups is a very, very fun lecture. So, and it's a very easy lecture as well. So let's see what we have to talk about in blood groups. Like blood groups have different systems. We can talk about a blood group in terms of two systems. Okay, and it's classified. Okay, it's classified based on antigens on the red blood cell surface. So each one of us has different antigens on the red blood cell surface. And depending on the antigen or the type of antigen you guys have, this is where you know your blood type. Okay? Now, how can you know that? Through two systems, the ABO system and the RH system. Okay? Those systems have to match for safe transfusion, blood donation, or if you're receiving blood or if you're donating blood, transplantation as well. Because if they do not match, then there would be tissue rejection. okay? So you're not going to be able to take up the organ or whatever. And pregnancy. So let's talk about each one separately. Starting with ABO system. This is the system where we are dealing with the antigens on the red blood cell surface, okay? And is determined by A and B antigens. So this is a red blood cell right there, okay? If we look at the antigen, it's gonna, and it has an A antigen, then this is someone who has blood group A. So A antigens, then you're blood group A. This is another one with B antigens. B antigens, then you're blood group B. Easy, right? Now, sometimes people have both of antigens. They're extra and they want both antigens. So they're going to express both alleles, A and B, on their antigen, on their red blood cell surface. And that's why we have people who are AB, okay? So blood group AB. Now, if you have a red blood cell that has no antigens, that's blood group O, okay? So it all depends on your antigens or the type of antigens you have on the red blood cell surface, okay? If you have A antigens, you're blood group A. If you have B, you're blood group B. If you have both, blood group AB. If you have none, you're O, okay? Like, but how does that even, like, how can we classify this? Like, how does someone, what determines the antigen to be either A or B or both or whatever? So we have this so-called H antigen, okay, which binds to something called fucose, okay? Fucose is basically a sugar molecule. And depending on this sugar molecule, we're going to know which antigen we have. So if we have an H antigen with an N-acetylgalactosamine, this is an A antigen, okay? So when we run the tests and we figure out that, okay, this is an H antigen attached to an N-acetylgalactosamine, this is going to be antigen A, okay, so you're blood group A. If someone has B antigen, it's going to be H antigen plus galactose. So realistically speaking, or logically speaking, if someone has both antigens, then you're going to have both sugars. So you're going to have the H antigen bound to N-acetylgalactosamine and galactose. And then finally, blood group O, they have no sugar to bind to. So their H antigen is alone. Okay, they have no bound fucose. All right? Like, how do we inherit those different alleles and how are they expressed in our body? So each person inherits two alleles from each parent, okay? And this is where dominance takes place, okay? So طبعا we have three different alleles, A, B, and O. So if you guys need to know that A is dominant over O, B is dominant over O. However, A and B, they're co-dominant, meaning that they're expressed together, okay? So A and B being co-dominant, if you inherit one A allele from your parent, from your mom, let's say, and one B allele from your dad, then they're both going to be expressed, and you're going to become AB. However, if you inherit one A allele from your parent and the other one is O, let's say, A is going to be dominant in this case, and you're going to have blood group A. Same thing for blood group B. O has to be recessive. O is recessive. So in order for someone to be blood group O, they have to inherit two O alleles. Okay? So basically, this summarizes what I just said. You have two alleles of A or an A and O. A is dominant, so you're going to have antigen A, blood type A. B, same thing. B is dominant over O, so you're going to have the B allele with blood type B. If you inherit the two alleles A and B, they're co-dominant, so no one tops the other. Okay, they're both expressed together, so you're going to have AB, blood group AB. However, the O is recessive, so in order for someone to have the O blood group or blood type, they're going to have both O alleles. And of course, they have no antigens, all right, as I mentioned earlier. Type. Now, if we have antigens, then we should have antibodies, right? So we have red blood cells, and on the surface of our red blood cells, we have antigens. So we're going to need to protect those, okay? We do not need antibodies attacking our antigens. So we're going to form antibodies to the opposite antigens because we do not want them to attack our own cells, right? So what I want you to know is that they're naturally in plasma. We're born with it. They're always in plasma. They do not need to be exposed to a certain type of antigen for the body to make antibodies against this antigen. It's already there. It's naturally in the plasma. It's going around your body or your blood. Okay. And it's always directed against the missing antigen. So let's say I'm blood type A and I have antigen A. So I'm going to make antibodies against antigen B, right? Because I cannot make antibodies against my own. I cannot make antibody A, because if I do antibody A, it's going to attack my own antigens. We don't want that. Okay, so if I have antigen A, I'm going to logically have antibody for B antigen. Okay, same thing for B. Okay, so let's take it one at a time. If you're a group A, meaning you have A antigens, you're going to form anti-B, so antibodies for B, okay? And they lyse type B red cells, okay? So in case if we have type A antigens on our red blood cells and we had invaders, which are type B cells, our body they're gonna have to attack those, okay? Because they're non-self. So we have antibody B. Same thing for group B, okay? Group B, it's gonna have anti-A that lyse type A red cells. Okay, what about AB? Now I have the A antigen and I have the B antigen. Do you think we have any antibodies? If we have both antigens, then who are we attacking? Like, we don't have any antibodies. Okay, excellent. So we do not have any antibodies, okay? For AB, okay, for AB, since we have two antigens, A and antigen B on our red blood cell, we're not going to have any antibodies, because if we have antibody A, then we're going to attack ourselves. And if we have antibody B, we're also going to be attacking ourselves. So we don't have antibodies at all. Now, O, since it has no antigens for itself, it's going to need to attack any other antigen. And that's why it has both anti-A and anti-B. Okay, so it both lyses both types, A and B. Okay? Like, why is this clinically important? It's very important for in case of blood transfusion, in case you're giving blood or you're receiving blood, okay? Because you cannot give a blood, like, you cannot give someone a blood type that's different than theirs because they're going to have a negative reaction going on, okay? So you're going to need to be careful with this. And this basically summarizes everything that I said. So whoever has A antigens, they're going to have anti-B bodies. Whoever has B antigens, they're going to have anti-A bodies. And whoever has AB, they're not going to have antibodies at all. And those who have O, they have both anti-A and anti-B, okay? What does O accept? O only accepts O themselves. I'm going to get to this, okay? Like, so this is exactly what I was going to talk about. So we have the recipient blood type and the donor blood type, okay? If someone has antigen A in their body, so they cannot accept antigen B, right? So when they receive blood, they're going to receive either A or O. Now A, because, okay, the antigen is the same as my antigen, so there's no reaction that's going to happen. Why O? We said O has no antigens. So my body is not going to make antibodies against this, so we're fine with that as well. Okay? Same thing for B. B can accept from B or O. Now AB is fine with everything, okay? So it could receive AB, it could receive A, it could receive B, it could receive O. Why? Because it has no antibodies. So there's no reaction that's going to happen, okay? So that's why we call it a universal recipient. A universal recipient is someone who could accept all blood groups because your body does not make any antibodies against any type of antigen, okay? And finally, blood group O, since it has antibodies against both A and B, so it cannot deal with antigens A and B, and that's why it only receives blood from their own group, O. Okay? And that's why it's a universal donor. Universal donor means it could give to all other blood groups. Why? Because we have no antibodies against type O. And why don't we have any antibodies against type O? Because we have no antigens. So remember when I told you on the red blood cells for O, they have no antigens on the surface. And that's why we have no antibodies against this. And that's why blood group O can give to all other blood types. Okay? Like, now we talked about the ABO system. Let's move on to the RH system. RH determines the sign of your blood group. So it's either positive or negative. So I'm pretty sure you guys know, most of you guys know your blood group. So you'd either be A positive, B positive, AB positive, B negative, O negative. So that negative sign or positive sign refers to the RH system. Okay? And how can we determine this? It's determined by something called D antigen. So if your red blood cell express D antigen, then you are positive, RH positive. But if your body does not express this antigen, then you are Rh negative. Okay? Type. So obviously, again, antigens means there's always an antibody. Okay, so if someone expresses a D antigen, there's always going to be an antibody attacking this in other patients that do not express the same antigen. Okay, so I'm gonna repeat. But before I repeat, in this case, RH system, the antibodies you produce is acquired, so they're not naturally occurring, unlike the ABO system. I told you the ABO system, it's naturally occurring. It's naturally there, okay? And it does not need prior exposure to the antigen to be produced. However, the RH antibodies, they're produced after exposure. Okay, so if they are exposed to a non-self antigen, the body's gonna start making Rh antibodies. Okay, like how can someone make antibodies uh, against Rh? Okay, or against the D antigen basically. So if you lack the D antigen yourself, so basically you're Rh negative. In case you lack the antigen, if an antigen D is introduced to your body, you're going to have to form antibodies against this since you do not have the antigen. Okay? So let's say an Rh negative individual that does not express the D antigen is exposed to an Rh positive. An Rh positive is an antigen. It's a non-self antigen. It's an invader. So what is going to be? What's going to happen? That the Rh negative individual is going to start secreting antibodies against this antigen. Okay. What about Rh positive people? Do you think they secrete antigens? No. I mean, secrete antibodies? No, because they have the antigen. So they have the D antigen. So if they're going to secrete antibodies against the antigen, they're going to be hurting their own selves, right? So Rh positive individuals have no antibodies. Okay? And here you go. If you have a D antigen or a D allele, basically it's dominant. So whenever you express the D allele, you're Rh positive. However, if you do not have the D dominant allele, then you're going to be Rh negative. Okay. Now, again, as I mentioned, transfusion or transplantation requires matching of both systems. Okay. So ABO and Rh systems need to be matched for safe transfusion. Okay. So what are the rules here? For ABO, I just mentioned that whenever you're going to give blood to someone, make sure that your blood is not going to make antibodies against their blood. Okay. Or if you're receiving blood, okay, you should make sure that the blood that you're receiving does not make antibodies against your own antigens. So if you're blood group A, just make sure that you're not receiving blood group B, because blood group B makes anti-A, and anti-A is going to attack your own antigens, okay? Second thing you should put in mind is the Rh, okay? If you're Rh negative, then you should not be receiving Rh positive blood, okay? Because Rh positive blood uh, um, would let your body make antibodies against it, okay? Now, how I like to remember it is that Rh negative patients, their Rh is negative, okay? It's negative, so it has a bad influence. It's negative, so it produces antibodies against the positive. So you know how negative affects the positive? So negative Rh would result in antibody production against Rh positive, okay? So if you're an Rh negative individual, you cannot receive blood from Rh positive person. Okay? You're only gonna have to receive Rh negative because your body does not make antibodies against your own antigen. Okay, or your own self cells or whatever. Okay. So this is a very great table for you to understand how this works when you combine ABO plus Rh system. So let's take a few examples here. A positive, we know that A only receives from A and O. Okay. Now, what determines whether it's positive or negative? If it's positive, then okay, you're fine. You can receive negative and positive, both. Okay. If you're positive, you're not gonna make antibodies against nothing, because basically the Rh negative does not have an antigen either way. So who are you going to be attacking? So you're fine. You can always, as an Rh positive individual, you can always accept Rh negative, but it does not work the other way. So if you look at H negative right there, it only accepts, okay, A and O, we know that, but it only accepts Rh negative. Okay. Now, remember how in the few slides earlier I mentioned that AB is a universal recipient and O is a universal donor. To be more precise here, AB positive is a universal recipient. Okay, so AB because it receives from AB blood groups, and O. And positive because Rh positive does not make antibodies against negative Rh. So we're fine. If we take blood from any type, we're fine. And same thing for O negative, this is the universal donor, okay? Because if you give anyone O negative, whether you yourself is an Rh negative or Rh positive, it's not gonna affect you. Okay? And blood group O, again, it has no antigens at all, okay? Uh, as a type on its own, it does not even have antigens. And Rh negative, it also does not have the D antigen. So there's no way anybody could form antibodies against O negative. All right. So please keep those in mind, the AB positive and O negative being universal recipients and universal donor respectively, because it's very high yield. All right. Does anyone have any questions? No questions? Okay. Well, I have a question for you guys. All right. Okay, good job, guys. You guys all got it right. So let me read it really quickly. 45-year-old man is involved in a road traffic accident, is taken to the emergency department. An examination reveals severe abdominal injuries and multiple fractures of hip and femur. The doctor on call decides a blood transfusion is necessary. The wife thinks the patient is blood group B negative, but is unsure. The most appropriate blood group to give the patient is what? So as you guys said, it's E, group O, negative blood. Why is that? Because that group O negative blood is a universal donor. So there's no way anyone could receive O negative blood and have a reaction to this. Why? Because group O on its own has no antigens on the surface. So there's no antibodies against any antigen. Negative, why negative? Why didn't we say positive? Rh negative is better than Rh positive, because what if the patient is Rh negative? Then it can't accept blood from Rh positive, right? So to be in the safest situation right now, we have to give group O negative blood. Okay? I think you should focus on everything. Just know the idea and the concept itself. But I'm telling you, the more high yield questions would normally be on about like O negative and AB positive. That doesn't mean you're not gonna get a question on other stuff. Just understand the whole concept. It's very easy to know. Just know what antigens make antibodies and so on. Okay, I'm just telling you that those are mostly high yields. All right. That's it. Do you guys have any questions? Anyone? Any questions? Okay. Well, that basically concludes my lecture for today, guys. Inshallah, hopefully, I hope you guys benefited very much or not, at least much, I don't know. I hope you guys benefited or learned something today. Um, of course, anytime you have any question, please contact me through my WhatsApp or email me, whatever makes you comfortable. I would be very, very, very happy to help. Where, inshallah, guys, it's a very easy exam. Just have faith in Allah and yourself. It's going to be a piece of cake, inshallah. And uh, just pray, okay, for khair always. And all the best for you guys. Genuinely, I hope you guys do amazing, amazing, amazing. Oh, that's all that I have. If you guys have no questions, then that's it. And please, I forgot to say this, scan the code. You'll find more extra practice questions for yourself. Practice makes perfect, so it's better for you. And you're also gonna find another feedback form. So I would very appreciate it if you guys fill the form because I would love to hear your feedback. And that's it. Thank you guys.